Low iron can crush energy. High ferritin can signal inflammation or overload. Most people don't know which story they're in, so they either ignore it, or they self-supplement iron like it's a multivitamin. And that's how you get the two most common outcomes. 1. You stay exhausted because you treated the wrong thing. 2. You treat fatigue with iron and accidentally join Team Rust. Today we're fixing it with a simple interpretation framework. Ferritin is not just iron high or low. It's storage and it's inflammation, and you need the full panel to know what's going on. By the end, you'll understand the 3 common iron stories, what labs actually matter, the traps that keep people stuck, and safe next steps. Food first when possible, supplement smart when appropriate, and clear, see your clinician. Red flags when it's not a DIY situation. Let's start with what iron actually does, because this explains why mild deficiency can make you feel 10 years older. Iron is essential for hemoglobin, which carries oxygen in your blood. It's also essential for myoglobin, which stores oxygen in muscle. But here's the part most people miss. Iron is involved in the electron transport chain, your mitochondria's ability to make ATP. So when iron is low, your energy factory runs underpowered, even before you're officially anemic. Iron also supports neurotransmitter synthesis and immune function. That's why iron issues can show up as fatigue, brain fog, low mood, exercise intolerance, and why do I feel like my battery is at 12% all day? Now ferritin, this is the lab that causes the most confusion. Ferritin is a storage protein for iron. Low ferritin almost always means low iron stores, and that's the easy case. High ferritin is the confusing case, because ferritin is also an acute phase reactant. It rises in inflammation, infection, metabolic syndrome, fatty liver, alcohol-related liver stress, autoimmune activity, and sometimes malignancy. So the rule is simple. Low ferritin is usually a low iron story. High ferritin could be an overload story, or it could be an inflammation story, and you can't guess which one by vibes. Here are the 3 iron stories you'll see most often. Story number 1 is iron deficiency, sometimes without anemia. Story number 2 is inflammation-driven iron trapping, often called anemia of chronic disease when anemia is present. Story number 3 is iron overload, like hereditary hemochromatosis, which is less common but important not to miss. Your symptoms can overlap across all 3 stories. That's why you don't diagnose iron status from fatigue alone. You diagnose it from a pattern. Story number 1. Iron deficiency without anemia. This is the silent trap. Hemoglobin can still be normal while tissue iron is low, because your body protects hemoglobin until it can't. So you feel lousy, but your CBC looks fine. You're told your labs are normal, and you assume you're just aging, stressed, or lazy. But iron deficiency can impair mitochondrial respiration and reduce exercise tolerance before anemia shows up. Common symptoms include fatigue, low endurance, brain fog, restless legs, hair shedding, headaches, cold intolerance, palpitations, and sometimes anxiety or low mood. In studies, non-anemic women with low ferritin have shown fatigue improvement with iron therapy, meaning symptoms can be real before anemia appears. Story number 2. Inflammation-driven iron trapping. In this story, your body has iron, but it's locked away. Inflammatory signaling pushes iron into storage and reduces availability for red blood cell production. This can produce a pattern where serum iron is low, but ferritin is normal or high, and TIBC is low or normal. People often misread this and start iron supplements, which can be useless or even harmful depending on the context. This is why CRP can be helpful. If ferritin is elevated and CRP is elevated, you should be thinking inflammation, liver stress, metabolic syndrome, infection, autoimmune activity. Then work upstream with your clinician. Story number 3. Iron overload. This is the story that matters because it's the opposite of take more iron. In overload, iron accumulates over time and can damage organs. The most classic cause is hereditary hemochromatosis, often HFE gene variants. Consequences can include liver injury and cirrhosis risk, diabetes, cardiomyopathy, joint pain, hypogonadism, and skin bronzing. The key lab clue is not ferritin alone. It's ferritin plus transferrin saturation. If ferritin is high and transferrin saturation is high, often flagged above about 45%, that's when overload gets much more likely and needs a proper workup. So what labs do you need to interpret iron correctly? Don't order one marker and guess. The minimum useful panel is CBC, ferritin, serum iron, TIBC, and transferrin saturation. And if ferritin is high or symptoms are confusing, CRP can add context. Here's a practical interpretation grid you can actually remember. Low ferritin, low serum iron, high TIBC, low transferrin saturation usually points toward iron deficiency. Low ferritin with normal hemoglobin is the classic iron deficiency without anemia pattern. Ferritin normal or high, serum iron low, TIBC low or normal often points toward inflammation-driven iron trapping. And ferritin high with transferrin saturation high raises the overload flag and deserves clinician-led evaluation. Now let's talk cutoffs in a practical way, because people love to quote one number and declare victory. A ferritin under about 30 nanograms per milliliter is commonly treated as clear iron deficiency in many clinical settings. Ferritin in the 30 to 50 range can be borderline, and symptoms matter, especially in athletes and menstruating women. A ferritin around 50 to 150 is often considered generally adequate for many people, but context still matters. Higher ferritin thresholds, like over 300 in men or over 200 in women, often trigger investigate thinking, not panic, but investigate. And very high ferritin, like over 1000, tends to be a don't DIY signal. That's urgent workup territory, because it can represent significant inflammation, liver disease, or iron overload states that need proper evaluation. Now the biggest trap: self-supplementing iron because you're tired. Iron is pro-oxidative in excess. Too much can be harmful, and acute overdose can be dangerous, especially for children. So the longevity compass rule is, don't supplement iron blindly. First, confirm you're in the low iron story with a real panel. Second, confirm you're not in an overload story by checking transferrin saturation and context. Third, fix the cause of deficiency, not just the number. If you are truly iron deficient, food first is the best foundation. Heme iron, from red meat, liver, and shellfish, absorbs better. Non-heme iron, from lentils, beans, tofu, spinach, and seeds, can help too, but absorption is more variable. You can boost absorption with vitamin C and by combining plant iron with some animal protein. You can block absorption with tea, coffee, and calcium taken near iron-rich meals. That's not bad, it's just timing. So if you're rebuilding iron stores, separate coffee and tea from iron-heavy meals by at least an hour or two. And don't take calcium at the same time as iron if you're actively trying to replete stores. Now the big dosing update that most people still don't know: daily iron isn't always the best approach. When you take oral iron, your hepcidin rises and can reduce absorption for roughly a day. That's why alternate day dosing has become a common evidence-based strategy to improve absorption and reduce GI side effects. A practical, clinician-guided approach often uses a moderate elemental iron dose every other day rather than hammering a large dose daily. This can improve adherence because fewer people quit from nausea, constipation, or "my stomach hates me." Important note: this is a conversation to have with your clinician, especially if you have GI disease, are older, or have complex labs. But the principle is useful. More frequent does not always mean more absorbed. Let's talk special scenarios briefly, because they're common. Restless legs syndrome often improves when iron stores are optimized, and many clinicians look for higher ferritin targets in that context. Thyroid symptoms can feel worse when iron is low because iron supports thyroid-related enzyme function. Athletes can lose iron through sweat, foot strike hemolysis, and sometimes GI losses, so endurance athletes often need closer monitoring. And in older adults, ferritin can be elevated from inflammation and metabolic issues, masking underlying functional iron deficiency. That's why the full panel matters. Ferritin alone can lie when inflammation is present. So what are the safe next steps? Step 1. Get the right panel: CBC, ferritin, serum iron, TIBC, transferrin saturation, and consider CRP. Step 2. Decide which story you're in: deficiency, inflammation trapping, or overload risk. Step 3. If you're in deficiency, fix the cause. That might mean heavier menstruation, dietary intake, GI absorption issues like celiac or IBD, blood donation frequency, or chronic low-grade bleeding that needs evaluation. Step 4. Recheck after about 8 to 12 weeks if you're supplementing, and watch both symptoms and labs. The goal is not to push ferritin to the moon. The goal is to restore adequate stores and feel better without overshooting into risk. Finally, the red flags. If ferritin is high, especially above common investigate thresholds, or transferrin saturation is elevated, don't self-treat. If ferritin is very high, if there's unexplained anemia, if there are GI symptoms or bleeding risk, or if there's a family history of iron overload, you want clinician-led workup. That can include repeat labs, liver enzymes, possible HFE gene testing, and GI evaluation when indicated. It's not scary. It's just the adult version of not guessing. Here's the bottom line. Ferritin is storage and inflammation. Low ferritin can be a hidden cause of fatigue even without anemia. High ferritin is not automatically too much iron, and the transferrin saturation pattern tells you which story you're in. If this helped, hit like and subscribe. Check the description for tools and affiliate links that match today's topic, plus our Longevity Compass Amazon KDP book. And if you know someone who's exhausted and stuck in the iron confusion loop, send this to them, because the right labs can save months of unnecessary suffering.